welcome to another Polestar Pilates Hour. It is an honor for me to have Adriaan Louw on our show again today. This time we really get to talk, just Adriaan and I, about everything about pain, anything about pain. And we certainly are opening up the platform for you to ask questions about pain and how we work with that. And one of the things that, Adriaan, you're originally from South Africa.
Correct.
And Adriaan has his bachelor's. I don't have it in front of me, but the main thing is that I always say is he has his FUD. So that's the PhD. And we always talk about, bachelor is BS, which we know what that also stands for. And an MS is more of that stuff. Yeah. And a PhD is piled higher and deeper. So we share that in common, both in the physical therapy profession with PhD. Adriaan is very accomplished and is very active in evidence in motion. He is one of the leading authorities in pain and pain education. You had a lot of programming at the last combined sections meeting. I sent out a little ping, Adriaan, to a lot of my colleagues at the university, and a lot of them were like, oh, I was there at this presentation at CSM, and I saw him at this at the combined sections meeting. I said, yes, I was in all of those meetings too. And I was talking. And this is an older version of one of Adriaan's books, and I've used it extensively for a number of years. Really, what I appreciate is making pain education available to clients and patients. And I think that's something to me that's very important. I've been looking at the belief models and behavior models since I started my research about 25 years ago. And what I love about this is in the Pilates world, I feel like we're on parallel things of how do we create positive movement experiences? How do we create positive educational experiences for the patients so that they perceive that they are getting better? And so I feel like you're one of the leaders in that. Your storytelling is probably the best storytelling I've ever heard. And I do want to talk about that today, of how did you get inspired to create the stories that the clients or the patients that are suffering from pain could relate to, and the fact that there's so many stories, there's so many types of things that people experience that we all label as pain, even though pain could manifest in many different ways and for many different reasons. So welcome, Adriaan. Good to have you.
Yeah, thanks for having me.
Time in your day.
Yeah, absolutely. Love being here.
Excellent. Well, let's start off with just a little bit about yourself and sort of your interest in pain and pain education, and where did that come from? A little bit about your history in, getting to the point. I know that you hang out with some cool folks, Lorimer Mosley and David Butler, and some great leaders in that industry. But what about you? Where did you get your interest in pain?
I wish I can tell an elaborate story, but the easy answer is I failed. It's not lost on me that I was trained in a very biomedical manual therapy world, and it worked for a couple of years. And then I started seeing more complex patients, and it just didn't work anymore. The models I was trained, the manual therapy techniques just didn't work anymore. And I was, dare I say today, I was kind of getting disillusioned with my profession, my choice of profession, and went back to South Africa on a trip, told my instructors how bad they were because they didn't train me for this. And then one of them pulled out a paper to tell me, hey, there's this cool thing called neurodynamics, or neural tension, in the 90s, by the way. And there's this guy from Australia, David Butler. And I came back, I read the paper. My now wife, bought me his book. I read 3 pages. I'm like, this is too hard to read. Went to a seminar, basically, Brent, and I sat in the front row center as OCD as I am. Good old David Butler walked in, and within a couple of minutes lecturing about pain just blew my mind. So it started this whole incredible, like, oh my God, this is amazing. There is way more to pain than just a joint, a muscle, a tendon, a ligament. And it started this process. The cool thing is just I got to know David because I'm from South Africa. He knew my instructors. He picked up on the accent, and he's like, where are you from? South Africa. Well, where about? We instantly connected, and I saw him at another conference. And before we knew it, hey, do you want to come help me at some of the seminars? I sign me up, I'm there. And, fast forward real quick, obviously significant mentorship of David Butler, significant mentorship later on with Lorimer Mosley. But it was David who told me, hey, dude, you need to get your PhD. This is something you need to do. So I started looking at the pain world. I had more questions than answers. And then we started getting into this idea of teaching people more about pain. Explain Pain came out in 2003, and teaching a lot. I mean, I was teaching on the road all the time, but again, more questions. And then once you build your own PhD pathway, you kind of get stuck in that direction. And we started building a pre-op program for P&E, pain neuroscience education for preoperative patients, which was then kind of my springboard from there on out. So that's fast forward, yeah, where I am.
Well, I mean, David is so accessible. Like I've met him a number of times, and it just is so nice to be able to sit down with him and enjoy his colorful wardrobe and, you know, talk about things. And he's just so giving of information. I think he was also a big inspiration for me as I was sort of looking at sort of the same thing. I think you know, I came from a very heavy manual therapy background in the late 80s, early 90s. I'd gone through all of Maitland, I'd gone through all of Kaltenborn, I'd gone through Rockabato, I'd gone through up in Canada, Dick Fike. And, you know, I'd really invested so much energy because I already had the Pilates. So to me, the Pilates was, you know, it was my TheraX. And then I wanted to really develop my manual skills, working particularly in the dance world, so that I could make change quickly. Like, how fast could I make change?
Yeah.
And, you know, there still was this big piece missing that we were not addressing, which was behavior and belief. And, you know, as I was getting ready and doing work in research, what I found was we had behavioral science. And I think like Jeffrey Lackner up in Buffalo, New York, that was, you know, a behavioral psychologist, and he was working with Nick Hopkins, who was doing neurosurgery. And the conclusion is people with chronic low back pain, looking at things like self-efficacy, fear avoidance testing, and these different psychosocial scales, that they were very powerful predictors of outcome. That was the main thing that they came up with. And that was in 97, 96. And but their conclusion was not favorable to us as therapists. The conclusion was diagnose, adios. If you get a high score on the self-efficacy, you're going to get better whether you have physical therapy or not. And if you get a low score, you're not going to get better whether you have therapy or not. And so it was a negative message for us. And yet I felt like there were things that we were doing that were making a difference, but were we measuring and looking at the wrong reason? Were we explaining it incorrectly? And I think that's where Explain Pain was a very powerful tool to our profession when it came out. I think that, you know, your research and your look at, you know, the whole neuroscience of education in particular really addressed the behavioral science piece that was missing from a lot of our education in the physical therapy and movement science world. And that's why I'm excited to have you today, and really to sort of hash out some of these models. And some of the things that I want to maybe clarify and you could explain is some of the different types of pain. You know, we so often just throw out there, you know, I have pain, or I have acute pain, or I have chronic pain. But there really is a lot more to classifying pain. Of how would you classify somebody, for example, that is dealing with pain that is emotionally sensitized, or that is catastrophized, or something that is undermined, like the people that have severe injuries and do not have the sense of pain. You know, they override it. Maybe they're an athlete, maybe they're military, but what are some of the categories for this audience? And again, just to reiterate, we have a nice mixture of you know, Pilates teachers and physical therapists that join the webinar that will be listening. So
how much time do we have?
We have an hour, and I don't control the time. And if we get through this much of the content, that's okay, because that's this much more of the content than they had before. So,
I mean, Brent, the easy answer is we have a tendency in medicine to make everything overcomplicated. I am very happy to say that today, in June 2022, as we're doing this webinar, I think the pain world is getting its act together in a sense, at least in the conservative realm. We identify 3 types of pain, and I think there's incredible research to back this. Yes, you can break them down into subcategories, but we believe there are 3 types of pain based on some of the underlying biology, psychology, physiology, etc. Nociceptive dominant pain, peripheral neuropathic, and centrally sensitized or nociplastic. If you understand the biology of how a human being experiences pain, those are 3 very different kinds of patients. We examine them different and we treat them completely different. One of the reasons we struggle so much in medicine is we just say somebody has pain. But the mechanisms are completely different. So just to put it in perspective, in the physical therapy world, we have now looked at the data. 55% of people that walk into PT clinics every day off the street sit in the nociceptive bucket. What do we mean by that? Those are the people whose pain experience is driven by joints, muscles, tendon, anything that's innervated. If I want to put it in another vernacular, it's the mundane, boring, everyday patients. They sprain their ankle, they have a knee replacement, they have very simple, non-complicated back pain, neck pain, knee pain, shoulder pain. That's our bread and butter. That's what's putting our kids through college. That should not put a lot of stress in your system. Those are the things that we are so well trained in. So check the box, be good.
And that's the thing is that is normal and that's expected. Yes. And we learn to respect it. We learn to decrease it as we heal. And that's the very normal process of an injury, of a legitimate cut, surgery, sprain, etc.
They go through the normal phase of healing. The nervous system does ramp up to protect a little bit, but then calms beautifully down in time of the healing phases. By the way, just take it one step further. In my world, the question is, do we teach these people more about pain? And the answer is not really. If a high school volleyball player walked in with an ankle sprain, grade 1 ankle sprain, and I spend most of my time teaching her about pain and don't do balance, proprioception, strength, range of motion, whatever, I have failed this young girl and her parents. The second bucket is peripheral neuropathic. And peripheral neuropathic is the ones where the peripheral nervous system is the main driver. So now we're talking about anything that's distal to the dorsal horn. This is going to be your lumbar radiculopathy, cervical radiculopathy, your cubital tunnels, carpal tunnel syndromes. Now the nervous system, which you and I were taught is a conduit, if you will, becomes actually a driver of the pain state. The good news is we're very good at these. We can pick it up quite easily. If you have any rudimentary understanding of something like neurodynamics, of a straight leg raise, an upper limb neurodynamic test, pressure algometry, most clinicians should be able to identify it, treat it effectively, and be okay. That's about 25% of our patients, by the way, Brent. So if you do the math real quick, that's 80% of our patients should sit in these, what we would consider your day-to-day, shouldn't be too hard to treat. Yeah. It's that last bucket that makes our lives very difficult. This is the reason we struggle. And that is what we call nociplastic or central sensitization is what we would often refer to it. In this case, the central nervous system, and now we're tying heavy into the emotional aspects, the psychosocial aspects, etc., which driving the pain. The central nervous system has been bombarded with information. It now upregulates and is the main driver. The ankle is better, the knee is better. These patients need to be examined completely different, and we need to treat them completely different. That's about 1 in 5 patients. And, the frustration for me often is therapists think of, chronic pain as such a big deal and it's so hard. It only affects really 1 in 5 in what comes in our clinic. And if you have the necessary tools to evaluate them, treat them. And by the way, these patients in the last bucket, and we literally teach our students buckets, there's 3 buckets, nociceptive, peripheral neuropathic, and central. And the people that sit in the last bucket are the ones that need more of the biopsychosocial, the broader spectrum treatments. They need cognitive therapy. They need movement-based therapy. We need to be careful of locus of control, make them a dependent, those kind of. So it's all these really cool pain stuff works for that last bucket really, really well. But Brent, I look at myself saying, well, I only have so many years probably that I'm going to be actively involved. But my goal is if I can one day get to that next phase of my life, sitting in a nursing home next to you, and we laugh about what we did here, I can look back and I have trained the vast majority of people that have crossed my path to understand there are 3 types of pain. We treat it, we examine them completely different, and we treat them different. I've made a difference. The cool thing is, and I'll stop here, the original research was done in 2012 by Keith Smart. In the last 2 years, there's been an enormous amount of research that has now validated that model that is 10 years old. And this is people like Paul Hodges has come on board and said, this stuff is really amazing. And so easy answer today, there's 3 kinds of pain: nociceptive dominant, peripheral neuropathic, central. We examine them different and we treat them very different.
That's a great overview. Matter of fact, that last combination of articles that came out in JSPT from Paul Hodges' plan it was probably the single best production of research or collection of research and commentary that I think our journal has ever put out. I think it just was, it was mind-blowing to think of all the many factors that, could influence us and, to get us to be a little more open in how we look at those things. And Paul Hodges was right on this, looking at the biopsychosocial, neuro, immuno, endo, every system, looking at how it impacts it. And one of the things I've noticed, I've been lucky the last 3 years, I've been teaching pathophysiology to the PT students. And it's really, really opened my eyes to realize that if we really are pathokinesiologists, right? So our specialty is movement. We restore movement. Whatever pathology impairs the movement is our specialty. That was a thing from Helen Hislop years ago. And that idea is, what we're looking at is if something that affects 20% of people coming in with some degree of chronic pain or chronicity of pain that we are missing, that's a big deal. And we either need to learn how to refer it out to somebody who can process it, evaluate it, educate it, create it, or we become part of that. And the piece that I want to talk about today really is that central group. And I want to bring in sort of your expertise and my expertise combined of saying, how do we combine this education, the language that we use? I love the stories you tell. We are on the other side creating these positive movement experiences that we can grade the load. We can make sure that they're, having these really amazing movement experiences that exceed their expectation, that are not increasing their pain, and their paradigm has to shift. The question is, if we as Pilates teachers and physical therapists are using catastrophizing and sensationalizing language, then we actually are a part of the problem with this population. That's where I'd like to go next, is talking a little bit about our language skills as practitioners, especially for the novice practitioner that is just coming into the realm of, and there's not a Pilates studio or a clinic that is not going to come across this 20%, the central pain generation. So where do we start learning, Adriaan, about, language and how we avoid catastrophization and sensationalization that often the novice does just to justify their existence? Unfortunately, the physicians often never learn not to do it. So they could be out, that's the worst disc herniation I've ever seen, Adriaan. It's amazing you can walk. Thank you very much. That set us back 6 months with your authority. How do we learn that? What's some good tools, and what is catastrophization? Let's just start there.
Let's start with catastrophization. Catastrophization is the inability to foresee anything but the bad. They always see the cup as half empty. All of us have a family member like this we invite to Thanksgiving every year, and they go, oh God, I got to invite Brent again because here he comes. Everything is negative. And we have a family, we call them Debbie Downers, right? But when somebody gets information, instead of attaching to the positive, they attach to the negative. That's it, life's over, bury me now, I have a bulging disc, I'll never walk again, right? It's that idea. So coming back to the word part, there's the beautiful phrase is obviously words that harm and words that heal. The words we use every day with our patients can either make people better or worse. They're not neutral. And so what's intriguing for us is, we talk always about the first rule of medicine is do no harm. So the first rule before you learn these fancy pain stories and pain metaphors is to not take your current language and make people afraid. So the words like torn, ripped, rupture, bulge, herniate, they drive fear and anxiety like nobody's business. Yes, we tend to point to orthopedic surgeons as our number one offender, but therapists are not far behind. I mean, Brent, you and I come out of the manual world of words like instability and spondylolisthesis, and these words that are like, oh my gosh, I hope it's not contagious, right? We scare people. So I don't know if people want to look. There was an amazing article in JWSPT in 2018, 2019, I think it was, Sticks and Stones. You guys can Google it. It's very easy to find. Yeah. That was amazing. That basically makes a list of, yes, it's just words that they use every day, that we should use alternative words. Like, degenerative disc disease is just aging of the spine, normal aging of the spine. If we can soften our language. So one of the things we talk about often is you have to de-educate to re-educate. So if you get sent to me with the idea of teaching you how pain works and I tell you a cool pain story, I have to first undo some of the bad thoughts that's in your system, like bulge, herniate, etc. So we soften our language with our patients, which brings in a very cool concept. Joe Nice, who's an amazing pain scientist in Belgium, talks about the idea we shouldn't be using pain neuroscience education. We should call it pain neuroscience communication. What it means is it's the fabric of what we do every day. It's Sandy Hilton talks about P&E should be the air we breathe. It's not a technique. It's not a thing we do. Ooh, Brent meets these criteria, let's do P&E. It's the way we talk to people. Embedded in this is empathy, compassion, respect, dignity, listening, active listening, all of these. But part of it is softening the words, right? Deconstructing when a patient walks in, I've got a bulging disc. Well, what do you understand about that? What have you been told about? Have you looked into it? Have you kind of de-threatened this? That's just basically step number one. You have to de-threaten it, but we got to be careful, because embedded in that, and that's so hard to do in a podcast like this or a webinar, is that embedded in that is you also have to validate your patient. Mm-hmm. You cannot just say, well, everybody's a bulging disc and move on, right? It's you got to listen. Tell me about your bulging disc. What do you believe about it? I can only imagine how you must feel. I can only imagine how you must think this impacts your exercise. So validation, respect, listening, and then slowly, by building a relationship, we start deconstructing this. This therapist with a funny accent is beginning to make some sense, because he's talking about a lot of people have it. It's not that big of a deal. People heal from it. Here's the really cool part, Brent, and I'll stop here, is I speak at a lot of medical conferences and medical groups now, and the number one request is to talk about words that harm and words that heal. Doctors are becoming aware of it. MRI reports are now listing your bulging disc information, and next to it, normative data. I haven't seen this in the history of medicine. So there is an intent in medicine to change. So I know and I do the same, right? We have our famous orthopedic surgeon who scares the life out of people. I think the medical world's beginning to get it. There are words that make people afraid. We got to take it out, explain it easier, and then we can explain to them, okay, well, then why do I hurt? Now we go to the P&E, the pain neuroscience education. Well, let me explain to you how pain works. Why is your pain not getting better? Why is your pain spreading? Why, when it's cold out, do you feel your back? Has anybody explained that to you? Now you start explaining to them the underlying biology of pain. And that's what our studies show make people better. Yeah. Once they go like, oh, I know what's going on. Their threat goes down. Their cup goes from half empty to cup half full. Like, oh my gosh, I can get better. Yes, you can. So we create hope. And so those are embedded into the model of educating people about pain.
And you're using a lot of spiritual words in there, Adriaan. So, you're talking about things like empathy and things like hope and things of belief. And, a lot of times an individual will associate that. And I'm talking more about the medical practitioner, the healthcare practitioner, will associate that with something that's out of my scope. I got to give them the facts. But the facts now are showing these very things you're talking about. For example, I saw a great study not too long ago that looked at, 1,000 MRIs of people who had never had back pain, right? I'm sure you've seen this one. And, like people over 50 years old, 89% or whatever of us have, major degenerative joint disease, facet arthropathy. We have, 60% have disc bulging and narrowing of space, 50% have stenosis and spondies and retros. And so, that when we start understanding the power also of understanding false positives, and that not everything is tied to an image diagnosis or a test diagnosis, that we need to get more information. The other thing that I liked that you just mentioned was, sort of almost like a neuro-linguistic approach to communication. And me saying, Adriaan, you tell me that you can't move your head. You feel like if you move your head, and it's attached by a string, the string will break and your head will fall off. So rather than me laughing at you, I'm like, Adriaan, if I understand you correctly, you feel like your head is attached by a string and you're afraid that something will break and it could be really dramatic for you. Is that right? Yes. Okay, well, let's think about that for a little bit. That's when the education come in. At least I validated, and that's where that NLP thing, validate that I heard you. I heard what you're saying. And the other, Carol Davis talks a lot about this in the interactive patient when she talks about interviewing skills. But these are the really powerful skills. It's like, what do you believe this diagnosis means to you? Like you said, what does the disc bulge mean to you? And that ties in nicely now with the ICF model. So what do you believe you should be able to participate in? How do you believe this diagnosis is impairing you from participating in these activities? And it is amazing the answers patients give us, right?
Yep. Oh.
It's not at all what we would typically cram down their throat if we didn't have time to listen to them, and what we would just explain them what the reason for everything is. It's amazing to me. Like I had one patient that said, God's punishing me. And that was the cause of her back pain, because God's punishing her. And she was, Católica, Apostolica, Romana, Cubana woman in Miami, and God's punishing her. And it turned out that there was some moral issue that was going on that she associated with it. And when, it was, it sort of gave her the options of, you can go talk to your priest, or you can change your belief habits or continue with pain. She all of a sudden realized that this was really a low back pain and she had to deal with it, and that there was an emotional component that was making it worse. And that when she had just that little bit of clarity from what she told me, I didn't tell her, she told me what was making it worse. Back in line with the language aspect of it, and I think this is so important. Adriaan, when patients come to us and they're seeing the glass half full, and this is a whole education process that you take people through, and I don't want to belittle the aspect of the training and the education that goes into it. But what are just a couple tips of how we can listen better? I think that's if we learn, I'll give you an example and then I'll let you take the floor again. I had my hip replaced 2 years ago, this month. And I shopped the whole world for the best orthopedic surgeon. I didn't care about a whole lot of things, but I had I wanted a certain procedure. I'd done my homework. I wanted on the MATA procedure on the certain table. I wanted it done by somebody who had done at least 1,000. I had my criteria. Yep. And I sit down finally with this Dr. Juan Suarez down in Miami. And I'd gone Chicago, New York, Colorado, Germany. I looked everywhere. So I want the best hip, right? I need the best hip. And I sit down, and every doctor, even though they knew where I came from, they knew what my background was, they knew I was educated, they all sort of stood up while I was sitting down, and they explained me, doctor explaining what was going to happen, right? And I knew more about the rehab of their procedures than probably anybody else, because I knew them from doing rehab of their very elite patients. Mm-hmm. But I sat down with Juan Suarez, and he sat down next to me, and we were looking at the x-ray, and he asked me a question, and he says, what do you think determines if you're ready to have a hip replacement, Brent? And I said, well, I'm struggling with something that nobody had asked me, but I was struggling with something. Yeah. And what I realized in that moment was I was struggling with the idea of being whole. It was like I'm an expert in whole body health, right? Whole body wellness, whole body movement. And here I was going to have my hip removed and have an artificial hip put in. And he very simply said, does whole body health relate to the body parts you have or your function? He didn't tell me, right?
Yeah.
He asked me. And in that moment, it was like, function. I'm on your table next week. Let's do it. And I had a pain-free surgery, full recovery. How do we learn to be better practitioners in that interviewing, in that questioning, kind of area? How do we learn to listen? What are some tips for listening?
Wow, man, you're throwing some tough ones at me today.
It's my specialty.
Yeah, I know. I mean, we can tell what we tell our students, right? Eye contact, eye level, all those kind of things. But I think there's more to it, though. When it comes to chronic pain, which is the area that we tend to specialize a lot in, there has to be truly I want to get to know the patient, the empathy, compassion. I know this is a really hard thing to wrap my mind around today, because all of us say, well, I care. I don't know if we do. If I'm listening to your story today and I'm thinking, a lot of the stuff we're talking about today, I didn't even know existed in my first 5 years of orthopedic practice. If a patient came into me and said, my pain's worse because I'm being punished by some deity, I would have said, you're full of crap, get out of here. I got another patient at 2 o'clock. Because that's where I was. And so, Brent, what I'm trying to say is we're all on a journey in our professional lives. Luckily, as you get older, you get more experience and things come to you. But here's what I have experienced is those people, therapists that really get to know pain and how pain works. And I want to go that way, that truly start seeing how complex a human's pain experience is. They are more intent to listening to the point of tell me more, I want to know more. There's a real interest in wanting to know. In the orthopedic model, it was more of and this is such a terrible statement, I know you guys are recording, but shut up, lay down, face in the hole, I'm going to crack your back. And there's a place for that. But I think as we get to know more about human pain experiences, there is almost this innate wanting to know more part. Also, when you see more complex patients, things just don't make sense. And, how does this work? I don't know. But we're becoming more aware of the things we don't know. So we ask more of those. Here's the interesting thing. Let me get away from this topic because I think it's way more complicated. We have shown that outcomes, we did some studies on this, which is really cool, really has nothing to do with time. I think this is important because every person listening today is thinking, oh, I know where Adriaan's going to go. You got to spend more time with your patient. And the answer is no. We have no data to prove it. We did a study where patients came in, we measured a bunch of stuff. I'm just going to say stuff. That is fear, catastrophization, movement, whatever. We mentioned a bunch of stuff. We then sat and interviewed them to tell me your story. And basically, we just, at the therapist's time, how long they sat with them, then they measured the same stuff. And then they measured some physical, so did a physical exam and then measured. And we showed that people are 25% better on their outcomes before we even start treatment. And it had nothing to do with time. So what I tell students often is be there, be present at the moment. Corey Zimney showed us some data to show that you build trust in less than 1 second. Trust is almost an instantaneous thing, but it's about being there, being present, wanting to know this person. And I'm going to very shamefully today say, when I was an orthopedic manual therapist, I don't think I wanted to know people. It was just a joint, a muscle that I had to do something to get him out, get him better, get him next. And it's no disrespect to my instructors. They were amazing. There's people you mentioned.
That's how we were trained.
That's how we were trained. And that's okay. But as you work your way through, the more I've learned more about pain, so maybe that's the answer I should give you today. How has it happened to me? The more I learn about the neuroscience of pain and how complex pain is, the less likely I am to cut people short or to interrupt them or to explain over them. It's because I don't know yet, because it's like, holy crap, that's interesting. I've never heard that. I need to go learn more. I've just become so vulnerable clinically that the patient's the expert in their pain. So tell me your story. What brings you here? This is a very tough question you're asking me.
I think you're answering. I think the key word is being present. One of the things we talk a lot about in Pilates and yoga and Tai Chi and Feldenkrais is being present, right? It's being mindful. It's understanding that there's something important happening right now. Like right now, I'm only interested in sharing information with you and learning from you, and I'm present. I'm writing notes down, but the other way, and I see this all the time, like I catch students that are, they're in my class and they're on their cell phone doing things, and I know they can't be present and be on the cell phone at the same time, or they're present in their cell phone, not present with me. It's very hard to be both. But I think that is a great question. One of the dilemmas we present to students sometimes is, you have to document. So you got your computer there documenting what you're doing, but the documentation is taking away from the contact you're talking about, of eye contact, same level, body language, being present, listening, appearing to listen, and building that trust relationship. I want to move into another direction. I appreciate that. I know it's a tough one, but I feel like what I wanted, and you did very nicely, is as we mature in the practice, we start to realize that we don't have all the answers. Yeah. And we end up getting maybe more complex clients that have more complex issues, more comorbidities, more psychological, social, emotional issues tied to the physical manifestations. And what I've learned as well is just that the patient knows what's wrong with them. They just often don't know how to articulate it. Yeah. And so if we can listen and ask the right questions, we often get a lot more information, and we don't, make those decisions before we walk in the door. I want to move a little bit into the centralized pain and talk a little bit about how you talk about the lion. You talk about how the lion increases, how things like anxiety, fear, relationships, finances, those things can sensitize the interpretation of pain. I think that's really important, maybe to spend a few minutes just talking a little bit about that and how those other factors are real. I mean, now we have research that shows that.
Yeah. To put it in context, one of the metaphors for the audience that we use to teach people about pain is a lion metaphor. And so the idea is, we will say to the patient, this story, by the way, that we often talk about works with people that often complain about fatigue or they have problems sleeping. So let's take a half a step back, right? The patient walks in the clinic and I will ask her, hey, Susie, since you developed fibromyalgia, what's the biggest thing that you struggle with? Well, Adriaan, I'm always tired, or I get wiped. Every afternoon I'm exhausted, or I cannot sleep at night. So we develop different stories for different problems people face based on the underlying biology. So in a patient like this, we may ask, we may want to explain this, and I will turn to the patient and ask her, has anybody explained to you why you're so tired or why you cannot fall asleep at night? And in 99% of cases, the answer is no, nobody's really explained. So we will then use a story, a metaphor, and I will ask a patient, if a lion jumped in this room right now, what would you do? And then you stop, you don't talk. In our treatment rooms, we have a marker and a dry erase board, and they write down, okay, and they'll write down scream, run, whatever they would do, right? Run, freak out, whatever. And then I will systematically go through a list of biological processes. So Susie, if a lion jumps in the room, is it time to take a nap? Yes or no? Well, no, they know the answers. They're smarter than we think. Hey, Susie, if a lion jumps in the room, is it time for you to save energy for the winter, or is it time to use energy? No, I need to use it. Good. So we don't storing. So we run through the systems, right? We use big muscles, not small muscles. So we work our way down, and then we sit with the patient. So what does this have to do with you today? Well, we know that all the things you're struggling with, and now you recall information from the subjective exam. You've seen 7 neurosurgeons, 2 orthopedic surgeons, 3 podiatrists, 9 PTs, 8 this. You got bills to pay, you got co-pays. We start writing all these, and all this stuff you're dealing with, stress, anxiety, life, relationships, is the equivalent of a lion. From the moment you wake up, there's a lion in your life. And what happens, your system shunts, but never shunts back. For me and you, Brent, today, when a lion jumps in the room, we freak out. We have that, fight and flight system, sympathetics. But when a lion gets pulled out of the room, we sink back in our seat and go, that's a 3rd lion attack today. This better stop. Our system is designed to ramp and calm. But Susie, in your case, this lion has been in your life for 3 years, 5 years, 7 years. So your system shunts. You never save energy, which means you get, and then they fill in the sentence, I get tired. Yes. When there's a lion in the room, are you going to fall asleep? No, exactly. They know but we are using a simple analogy. And then the question comes, what do we do about it? Well, Susie, how do we make this lion smaller? Well, now we talk about nutrition, we talk about sleep, we talk about mindfulness, relaxation, movement, all the cool stuff that can make your lion smaller and smaller and smaller and smaller. And when a small lion enters the room, we don't freak out. We go, "Aw, little baby lion." Right. And so I know this sounds silly. I know the audience right now is probably going like, this is so stupid, but it's the latest neuroscience put in a simple little story where a patient sits there and goes, "Oh my God, that makes total sense." And we have systematic reviews, meta-analysis to show it's thinking freaking works. Yeah. So that's how we would do something like that.
And I've used it successfully as well, Adriaan. I love the analogy. And one of the products that you've put out is the fibromyalgia workbook. And I've used that a lot with a lot of my patients when they come in, and we just go through the lessons, and we take one lesson a week if they can handle that, maybe not. But going through each of the lessons, and it's sort of helping them, and they go home and think about it and work through it. And again, I would say there's nothing that's bulletproof. I know a lot of people think, when you're dealing with chronic pain, I don't know anybody that claims 100% outcome dealing with chronic pain, but you have to figure they already have failed everybody else. And if we get 25% or 30% that are actually getting back into the quality of life, they might not ever be pain-free, but if they can get back into a functional quality of life, then kudos to everybody. But I really like the premise of the fibromyalgia workbook that you have. We'll put the links into the post-production for everybody listening. But what was sort of I know the idea behind it is, again, tied into education. You labeled it fibromyalgia. I use it with anybody with chronic pain. I hate the word fibromyalgia, but explain a little bit of what it works great with people with fibromyalgia diagnosis. Why? Like, why did you choose that name?
Well, because fibromyalgia is obviously a complex condition that affects millions of people. Yeah. We wrote a paper a couple of years ago called "Treat the Patient, Not the Label." Their labels change all the time. If we had to sit here today, make a list of all the different labels between, chronic Lyme disease, fibromyalgia, irritable bowel syndrome, the list can go on and on and on. Chronic fatigue syndrome, which has now changed its name as well. The underlying biology is absolutely intriguing. If the current thought process in the neuroscience world is that in a condition which you and I would label as fibromyalgia, is that the immune system plays a significant role in sensitizing the peripheral and central nervous system. And so that we understand the mechanisms better, but that doesn't help the patient, because I came to you with my fibromyalgia. If I take that label away from you, I might as well cut your body in half. So with patients, we validate them by using their label. For example, we talked today about words that harm, words that heal, but yet you and I today use a horrible term today called bulging disc. If a patient sits with me and say, "I have a bulging disc," I don't ignore them or never use that name because, "Oh, it's a bad, don't ever, that's a swear word." No, tell me about your bulging disc, because I hear you and I validate you. Fibromyalgia, unfortunately, Brent, has just created such an incredible labeling system behind it that, we can call it whatever. And you're right, you can literally take that book, rip the cover off and call it chronic pain workbook. We just happen to focus on a subset of people. And what the data is showing us, people want that. They don't mind chronic pain, but here's an example. We did a big study where we went to big city centers all across the United States. I would show up for 2 hours on a stage, fill the auditorium with hundreds of people, rah, 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 this is how pain works, and we're going to change the world. It didn't work. People had a great time. There was cookies, there was some drinks, they had a great time. We laughed, we had fun, whatever. And then they would all line up afterwards and shake my hand and say, "That was awesome, but let me ask you about my pain." Pain is an individual human experience, and we need to be careful of labeling. I know these labels are terrible. They don't tell us much about fibromyalgia. Tells me nothing what's happening below the skin, in the system, in the brain, in the amygdala, whatever. But that's what the patient chose to call it, has been labeled as. And so unfortunately, our medical system is, I need to still treat people with fibromyalgia, chronic fatigue syndrome, etc. But you and I know, and hopefully our audience today would know, the underlying mechanisms are very similar biological processes. But yeah, you're correct. We could rip that cover off, call it the chronic pain workbook. But for fibromyalgia, just because it affects 10+ million people, it just seemed to there's a subset of people that really identify with that label, if you will. And we wanted to give them specific things for their struggle that they're dealing with. Yeah.
Yeah. Thanks for explaining that. I think that, like I said, I've used it quite often with patients to have at home and to work through the workbook, come back in a discussion. I've never been able to have a group discussion. I've always thought that would be great, is to have a support group that comes in. But I've also always been very careful. Like when I have a chronic pain patient come in, I always say, there's two things you can't do. One, you can't be part of a chronic pain support group where everybody's comparing their catastrophizing symptoms. And two, you need to go out and do some service in the community somehow or other for an hour a week. Yeah. You know, whether it's a phone calling service or helping out in a food kitchen or something, do something for somebody else. But but the power of the content inside that workbook is very good discovery for the client. So the thing I want to go into last is what I started with, which is the stories. And the stories that you have created with your team and through the years, what I find most importantly is that you're looking to match a story. And we're not going to go into the education of this because it's a full education process, but more the concept of having a story that a client can relate to and understand, just like we talked about the lion.
Yeah, it started way back. We interviewed a lot of people with chronic pain to find out what are the most common struggles. And it's simple. There's 6 of them, Brent. People with persistent pain struggle with persistent pain. My pain's not getting any better. Pain that spreads. Pain that spread is very freaky. Wait a minute, my pain is now going to my knee, to my back, my leg. By the way, fatigue is another issue. Sleep is an issue. Pain, odd pain. We call it odd pains. Pain when it's cold. Pain when I'm stressed. I feel my neck. When it's cold, I feel my knee. And then also I developed this fog. I forget things. I cannot focus anymore. Those are the 6 biggest ones. And so we went and studied the underlying biology. And so now when a patient comes to us, and I literally do this with patients, I ask him, hey, Frank, since you had a knee replacement, what's the biggest thing that bothers you? Well, when it's cold, I feel my knee. So, and then I would ask him, has anybody explained that to you? Well, no. And typically they haven't, because nobody understands it. And then we built a story to explain to him ion channel expression, but not in those terms. We talked to him about nerve sensors. And we talk about car sensors. So when you drive down the road, your sensor goes off and says, hey, you need gas. Does that mean there's something catastrophically wrong with your car? No, it just says you need gas. Well, our body also has sensors, and our sensors that can tell us how hot or cold it is today in Florida. There are sensors that are telling us if we're too stressed, we need to be careful with our stress. There's sensors, and they're all balanced. And when there's a cold front coming, there are just more temperature sensors that tell us, hey, it's cold out. Make sure you put some long pants on or whatever. So these stories are designed to de-threaten the pain experience, where they go, oh, that's what's going on. Exactly. And we have studies to show pressure pain thresholds, fear avoidance, catastrophization. These things all positively shift. And that makes him then your candidate. And that's the movement candidate. Yeah. People that are not as afraid of their pain anymore are now prime candidates for the most powerful thing to change pain, and that's movement. People in pain just don't want to move because they're afraid they're going to undo their knee or make their back worse. It's like, no, your back is sensitive because the alarm system is on full alert right now. It's trying to protect you, but there's nothing wrong. Your back is healed. Your back is getting better. Tissues heal, right? So it's the educational model is designed to facilitate people to move. And that's where we really want to get them, because that's actually where the therapy happens. They're just afraid to move.
Yeah, and I think that's an important message. We're not doing tissue damage when we're reinstigating movement and moving the body. And a lot of times if you ask, what do you think is going on? They're afraid. Like I had somebody that was afraid that their rib was going to pop out because she'd been told she had a sublux rib from a coughing spell during a COVID bout, right? So she had a COVID bout, she had a sublux rib, and she was afraid if she moved that the rib would pop out. So not understanding that, there's capsules and there's the joint and there's all this other tissue, and that we could get the muscle spasms to release and get it to feel a little bit better and calm it down, and maybe even get a little audible click, that would tell us that, it's sort of back home where it needs to be. But it was like the fear that something was going to break again, or something's going to fracture, or those things completely changed the movement strategy. And so her movement strategy was one of absolute protection when she didn't need to do that. And so when we were able to introduce the movement to her with very gentle and then progress it to what she wanted to be able to do, she was like, you mean I've been protecting myself for this last month without needing to? I said, well, it's hard to know. Your body's telling you what it needs. And now we discovered that you can move, so you can move. And she had a really good experience.
But wait a minute, you have now done and explained exactly what's happened to me. And that is, you've come full circle. I was in a podcast recently, and somebody asked me, again, I don't know where the question came, but they said, why are you so good at pain? And I said, because I'm a good manual therapist. You can only, and this is truly become full circle, Brent, because on the one hand, people are sitting here thinking, oh, Adrian's kind of bashing on manual. No, the part, you cannot talk somebody through movement if you cannot go examine him to make sure that that rib did not dislocate, right? So,
Yes.
so I have become full circle to say, you know what, I think the reason my patients trust me and respect me and believe me, my education, is because I did a thorough evaluation and I thoroughly reasoned to show them your rib is okay. It cannot do A, B, and C. And so I think sometimes we think it's either or. I'm either a good hands-on manual therapist or I'm a pain person. No, I think it's those fundamental skill sets, because knowing what you know about ribs and the anatomy and the mechanics gives you the strength to explain to somebody that it cannot do that. That's why we got to do A, B, and C. So again, the message to the audience is obviously all these other educational things we do, from kinesiology to biomechanics to all these other skill sets, are critical parts of building this repertoire, building your persona to give you validity. So when somebody has to make that split second, do I trust Brent and start moving because he just told me the rib is okay? And so I think it's important that those skill sets are there as part of this journey that we're on.
Yeah, that's great. I think that, to me, one of the things looking in the future, and this was part of your presentation in CSM, was how the successful movement experience paired with the education for this particular population really was like an enzymatic reaction. Like it was a catalyst that really put the icing on the cake. Can you talk a little bit more about, the successful movement experience? Because to me, it's like, you just went through the whole thing. Like we have these manual therapy, diagnostic, and now behavioral skills. So let's say that we've acquired this and we've taken somebody to that level. Maybe we manipulated that rib, got a nice little audible correction. They got a relief with it. We taught them about it. We taught them what their experience. But now, to me, one of the most crucial parts, and something that I feel really strongly about, and that's why it was music to my ears when I heard the research being presented at CSM in your presentations with your team, was how valuable movement was as sort of that last piece. It creates the independence. It creates the self-confidence. It overcomes all of these fears that they've been dealing with, having had chronic pain.
Yeah, let's just call a spade today. Education to behavior change is like throwing wet spaghetti to a brick, right? That's Bill Forey's famous quote. We're not going to change a human being's behavior by educating them. We spend $2.1 trillion telling people smoking causes cancer, and 1 in 5 will go, yeah, I should stop smoking. What changes behavior is, in the therapy medical pain realm, is movement. Movement is the single biggest painkiller on planet Earth we've ever studied. I want people to understand that there are studies upon studies to prove it. The problem is just people in pain are afraid to move. They want to move, they should move, but they won't move because they're afraid. What P&E does, or CBT, or acceptance commitment therapy, whatever your cognitive bent, motivational interviewing, whatever it is just to get them over the hump where they go, I'm going to be okay. Yeah. And then with graded exposure, for graded pacing, we slowly move them little at a time. But the ultimate goal is not to, we don't explain pain out of people. It doesn't, I wish I could. There's maybe been 1 or 2 people that are like, oh my God, I got it, I'm gone. You don't.
It's funny that you say that. That study I was talking about, Jeffrey Lackner up in Buffalo, New York. The reason why he came to the conclusion that you could not change the belief pattern or the paradigm was because their intervention was a behavioral intervention. So when I asked him, what were you doing? It was like, well, I'm having them think about lifting that box without back pain.
Yeah.
And then they went over and picked up the box and they had back pain again. And so it didn't make any difference when I was trying to change their behavior using, cognitive skills. And I thought, well, of course, they just had another negative reinforcing experience with the actual movement that they're afraid of to begin with. And you might create 1 or 2 sessions where they're going to believe you that they can close their eyes and imagine doing the movement without pain. But if you didn't address their strategy of movement or the load of the movement, they're not going to have a good positive experience. Yeah. And all we're doing then is reinforcing the whole neural chain on that. So this has been great, Adriaan, and I think that there's a lot more for us to collaborate in as far as the idea of how in the Pilates world we use an environment that allows us for whatever reason, maybe it's a foreign environment, it's a graded load environment that Peter Sullivan talks about. It is foreign enough of an activity. It's sort of strange for people to get onto a machine that has springs attached to it, but it's as old as dust. I mean, if you think about polio days, they had the Guthrie Smith tables, the same thing as the trapeze table in Pilates. And they had it because they had to assist the motion with people who had under a 4 out of 5 muscle test. In Europe, and I imagine in South Africa as well, things like the Slingentisch that came in the German and the French and the Swedes and the Norwegians that had tables that were designed to allow movement with modified load. And so none of these concepts are new. And that's what I love seeing, though, is for things to come together where we're finally seeing the evidence supporting this type of communication that we've talked about today, supporting the education, supporting movement therapy, supporting manual therapy, supporting, most importantly, assessment skills. Like, how do we differentiate? There was a question that came up earlier that you answered that was, do the 3 buckets ever cross over? And, and of course the answer is
yes.
Yeah, of course they do. But the idea is like, how do we prioritize? How do we, tie it into, for example, the ICF model of what is it that they believe is their level of participation and why do they believe they can't do it? Because if we get them participating at that level or doing that activity as quickly as possible, and I come from a cash pay practice model for over 20 years, and I figure I got 2 visits to get a 60 to 80% improvement in function, not necessarily pain reduction, but I got to make a difference very quickly. And if I didn't, kudos to your statement, if I didn't have those manual therapy skills, and I didn't have communication skills, and I didn't have movement education skills, there's no way that I could address that kind of success level with that kind of business realm. Like, I have to be able to make change. I depend on that. So any last words you want to share with the group, Adriaan, before we lock down today?
Yeah, I think I'll finish with the, when our pain fellows graduate, they get their fancy certificate, but we also have a plaque, and the plaque is Theodore Roosevelt's quote: "People don't care how much you know until they know how much you care." And so learn about pain. We got to teach people about pain, but they have to have the empathy, compassion to really want to help somebody, because I think that's critical. So if you sit with a patient, you have no idea what to do with them, just listen and show them you care. That itself is extremely therapeutic as a start.
It's at 25% almost reduction. And that's the difference between being a 7 and a 5 out of 10.
Yes.
That's a world difference for people.
Yeah.
Well, Adriaan, thank you so much. Thank you for all you do for the profession, your leadership, your humor, your humility. Appreciate that example very much, and look forward to working with you again soon. I had a chance to be on a podcast recording with your team, and that went really well. I hope everybody's happy with that. So we have more to come, more excitement to come, collaborating. I do want to remind the audience that there are a couple seats left in the critical reasoning course that is in person in North Carolina at the Southwind Retreat Center. So that's in a couple of weeks. We'll send you out the link to it. I think we have 3 or 4 more spots left until we're full. And until then, Everybody have a great weekend. Remember, today's a good day to have a good day. There's a lot of craziness in the world, and send your thoughts and your prayers out to those in Texas, in Buffalo, in Ukraine, and other individuals you know that are suffering from the challenges out there. And most importantly, be kind. Thank you again, Adriaan.
Thank you.